Some of you might have seen on WhatsApp a cartoon circulating. There are two windows. One window says junk food, alcohol, ayyashi. The other window says healthy lifestyle. And 99% of the people are standing, you know where, right? So, today we are faced in this medical legal session, we are going to talk about only one new thing that we are facing. There is a business opportunity worth crores of rupees. That business opportunity allows a comfort to the patient party, and then what is the science, what is the evidence, and what is the safety of the patient goes for a toss. And what I am referring to is chemotherapy being administered at home. Okay. So, the entire session today we are going to focus only on this, and very interestingly we have divided into three specific points, and we have some real good experts going to talk on for as well as against. And I will call them one by one, and when their session or their lecture is over, I would invite them to join us here so that we will have a good panel discussion as well. So, the first statement is, today patients are eager to receive chemotherapy at home. We will have Vivek Agarwala speaking for, and we will have Bhavesh, Poladia speaking against. So, may I invite Vivek Agarwala, please.
So, thank you, sir. So, today patients are eager to receive chemo at home, and I think we should be ready to comply wherever feasible, because since when we were not listening to patients and doing what our patients wanted. So, what patient wants is very important. Now, recent advances that has happened in the technological advances has enabled us to give some forms of anti-systemic therapy, in fact many forms of anti-systemic therapy at home. In just the last lecture we heard about oral cabazitaxel. We have been hearing development of oral taxanes, oral platinums. We heard just Phesgo has come. So, the intention is to easier home administration, and definitely we are going towards more and more molecules and which are making it easier for patient to get treatment at home. Of course, the specific treatment protocol needs to be prescribed, the caregiver availability needs to be ensured, there must be enough motivation and training of staff there at home, as well as the relatives and people at home. The home environment and location should be suitable, patient characteristics, morbidities, fitness, they all need to be looked into, and safety should be uncompromised. But then within these parameters also it is possible. So, home based treatment is something that is already happening. Oral drugs we are already giving, this is home based treatment only, and hormonal therapy we have been using fulvestrant as well as leuprolide injections. Many of the patients, my patients are taking them themselves at home by with the local facility. They are not coming to us for these injections. Many targeted therapies are also my patients are taking, and some of my few patients they have even taken immunotherapy at home. So, this is already happening. I am sure this must be there in your practice also. Now, what happens at hospital when the patient comes? What are we really concerned about? So, obviously when the patient comes, there is a skillful preparation and delivery. This is one thing that happens. Of course, there is monitoring during the treatment that happens in our hospital, and there is obviously the availability of paraphernalia and safety, toxicity, acute reactions. These things are ensured and it is handled. This is what happens. But if these things can be ensured at home, then what is preventing us from giving at home? Is it actually the insecurity that our business will stop? Is it actually the discomfort of going outside our arena? Is it actually the extra headache that we have to take? So, these are these the actual reasons why we don't want to do it? or you know, because we have to ultimately listen to patients, and if we don't do, somebody else will. Now there are scientific studies which tell us evidence towards it. This is the outreach study, and here patients were given at hospital, at home, as well as with the GPs, and they looked at quality of life, patient satisfaction, safety and health economics, and there was no difference in quality of life between the treatments. There was significant difference in the favor of home in quality of life between the two community locations. There was no evidence that at home safety was compromised, and when patients were asked where they would want to continue for the next, 90% at home wanted to continue at home, whereas at hospital 57% wanted to continue. So it favors at home. This is another study where in the survey 95% of the patients preferred at home, and there was no statistical significant difference in adverse events that was outreached. This is another study where they looked at the top reasons for choosing, and these are quite important reasons why they want to do at home, because you know, they are able to be free of hospital required infections. There is a concern, there is ease of parking at home. They don't have to, you know, bother about parking. They are in familiar surroundings. There is concern about treatment waiting, whereas at hospital, why they would want to continue? Because they want to be with other patients, they want to keep a routine, they have access to support devices, access to doctor and medical. These are the top reasons. So at home there are reasons. If the patients are for these reasons they want to choose, they can. Again, another Australian study, they looked at advantages. There were similar advantages at home that most patients expressed, and this is another study which looked at the cost. In this study the cost was comparative at home, but this is another study of from Thailand, where Folfox was given at home, and there was a cost saving when this Folfox chemotherapy given at home in Thailand in patients. So there are guidelines also. This is NSW Cancer Institute guidelines, this is NHS recommendations. So to summarize, of course home treatment services are suitable for many patients who are receiving systemic therapy including chemotherapy, and the reported advantages in the home include elimination of travel, reduction in treatment related anxiety, reduction in the burden on carers and family. They are able to continue with their life, they are able to continue what they want to do, the duties, there is less cost involved, and there are no significant complications and of course identification of the correct patient is the key. So with this I thank you again and I put my case. Thank you.
Thank you, Vivek. Please join me here. Bhavesh, you are going to speak against the statement.
So good evening one and all, and thank you for the whole ICON team to give me this opportunity. Warm greetings from my hospital, Nangam Cancer Center. I have to speak against the organizer, the host. Very difficult task. I think if I go very strong, I will not have my dinner today. So I have to be a little dumb. Let's debate. Let's see who wins. But I'll keep myself as focused as possible and as short as possible. So chemotherapy, we do understand it's a life-saving drug, but rarely chemotherapy is used as an emergency drug. Of course, Vivek has already told we require special skills, not only to reconstitute the drug, to deliver the drug, and even more important, to dispose the drug. So according to me, what are the drugs which are safer to be taken at home? I think oral drugs are the only drugs which are safer to be taken at home. All other drugs which needs assistance should be given not at home but at a facility where patient can be monitored properly. Like Vivek mentioned about Fesgo. So it's a subcutaneous injection, very very enticing to hear that. But my friend, even Fesgo needs a very specific training. Even the Roche people are actually asking the sisters to come, get trained, and then give it. That also into a non-home facility at the health facility. So what can go wrong? So the most important thing, or the first thing when we become a doctor, the only thing what we have to take into account, which is first, is do not do any harm to the patient. If you cannot do any good, at least don't do any harm. That is the least expected out of us. And we cannot forego this. Because what can go wrong? Every step can go wrong. Taking an IV line, it can be a problem. Extravasation, we know it can happen and it can be very bad with some chemotherapeutic agents. Regular monitoring again is a very important during an infusion, because many a times patient may have a fluctuation in pulse, pressure. Not only that, even specific symptoms during the infusion like chest pain, as you were telling about fall fox, you cannot do an unmonitored fall fox at home. Patient gets chest pain and he may die at home. This was for the patient, but even if the reconstitution is done not in a bio cabinet and it is done in the open air, it is not safe for the family, for the personals who are actually doing it, and same thing is for the biomedical waste. That is why we have very strict policy. Even in the hospital, we have to maintain this biosafety cabinets. We have to maintain that biomedical waste disposals very, very properly. So if we at all have to do it, we need a very skilled personnel, but we do have a lack of manpower. We are in India, we are not in Australia. So it's very difficult. We have to use our manpower very judiciously. Creating an ideal setup at home, I think it is very, very difficult. We are struggling here to get a CEA certificate from the government, and you are asking to set up a thing at home. Very, very difficult. Needing an intensive care unit close to, because if any emergency situation arises in a good city, probably it is possible you can get an ambulance easily, you can shift the patient to ICU. But my friend, if it is a remote area, very, very difficult. You will not even get a vehicle to come. So in spite of doing all these things, be ready for the worst. You are doing everything good for the patient. You are trying to satisfy all the requirement of the patient, but finally if anything goes wrong, my friend, you are the one who will be always held responsible. So special situation, like emergency situation like COVID pandemic, we can understand, but not all days are COVID pandemic. So we have to understand what is feasible and doable in routine practice. Another thing what we can understand and we can still deliver at home is a palliative care alone at home and not chemotherapy. So I think in India it is a resource constrained country. We cannot use our handful of manpower which are very, very skilled to go and deliver one patient at home. Giving chemotherapy can cause risk not only to the patient's life, patient's family members, and it also can risk risk your life and reputation also. So thank you. That's what from my side. Thank you.
I think we gave too much time to both the speakers. 4 minutes was too much. Therefore, instead of focusing on what the patient needs, they were talking about why it should be given and why it should not be given. So let's go to statement 2. Daycare chemotherapy nurse does not require any more treatment or training, training to give chemotherapy at home. 4 is Kshitij Joshi, and against is Vinayak Maka. First, Kshitij Joshi, please.
Thank you. Thank you, sir. Thank you, organizers, for giving me this opportunity. It is very difficult to debate on this topic, and also in front of my senior from GCRI who is going to speak against me. So let us start. The statement given to me is a daycare chemotherapy nurses does not require any more training to give chemotherapy at home. So I was just thinking over it, what are the points on the basis of which we are little afraid about, and what are the problems related to chemo at home. First is management of hypersensitivity. Second is chemo preparation at home as suggested by Dr. Bhavesh. Chemo setup, stands and all these things were not available maybe. IV line, port related, PICC related issues. Bio waste management, very important. Vital monitoring and emergency management, the last and the most important thing, which includes intubation, CPR, ICU shifting. So these 7 points, when I was thinking, these 7 points come to my mind. So what we are afraid of, the most common and the most serious is the allergic reactions. Everybody is aware of what are the allergic reactions. It is the cardiovascular reactions, neurological, all these are there. So let us go to a real data. This is a MOC data, last 1 year. our own practice, which is last month there was a 2000 chemotherapies was happening, and if you consider a year, there might be a 20,000. Out of this 20,000 chemotherapy happening in a daycare setup, there were reactions noted in 21. And these are little reactions, means we define the reaction, not milder one, the reaction that is responsible discardation, we have to discard the medicine. There were 21. And out of this 21, during entire 1 year, only 8 shifting were required to ICU or hospital, and there was no death recorded. And out of these 8 patients, 2 were previously having little pleural effusion, and that was the reason of the breathlessness. This is the real data that we are having. So let us go to the other data that after discussion with my Tata friend, he said that there was 10,000 chemotherapies are happening per month in Tata, and they requires only shifting once or twice a month, which is a small percentage. For non-taxane, non-antibody transfusion, chances are even lower. So chemotherapy nurse working in daycare and hospital they know well how to handle these kind of hypersensitivity. This is my comment. And if infusion and intubation and CPR training is required, and this is there with the nurses, they can handle this emergency very well. These are few points. So now let us come to the second point. Chemo preparation, bio-waste, definitely aerosol, that during chemo preparation is dangerous for patients relative at home. So, but there is one option. Nurse can do chemo preparation at a daycare center, and they can transport at room temperature. This is feasible. So that is one thing. Second thing, there are many, this is bio-waste. Bio-waste is a dangerous thing. We cannot discard it. So we can use appropriate bags, and our all sisters, they are trained, they know how to collect it, and this can be carried back to a daycare center and discarded. So then there is a point of difficult veins. Tell me frankly, who is the one who can take a best IV line? They are the sisters. Then the port, PICC, they are handling better. And if they are handling better in the daycare or even at a home setup, it is the same. Now let us come to the first point. So are there enough nurses to take care of chemo at home? So there is actually what sir has first pointed out. There are not enough nurses. So let us go to the statistics again. If the Indian Nursing Council records we see, there are total nurses 33.41 lakhs. Registered nursing personals, which includes nurses and midwives 23.4 lakhs. Nurse to population ratio in India 1.96 up to 1000. Total number of chemotherapy trained certified nurses, according to Trained Nurses Association of India, India produces approximately 2 lakh nurses every year. 40 to 50% leaves India. So frankly, it is very difficult to obtain a specific certified trained oncology nurse. But a registered nurse working in the cancer hospital or a daycare center, have a clinical experience of 3 or more months, and capable of handling and taking enough decision in a case of emergency, can provide chemotherapy at home. So that is what. So let us go to the problem again. These are 7 problems. Management of hypersensitivity. Will it differ at home or a daycare? No, the same drugs a sister can give. If the sister can give at daycare center, definitely at home. Chemo preparation at home, not advisable many times, but can prepare at daycare center, can travel and can carry with him, her. The chemo setup can be arranged, IV line, port, PICC, everything sister can do on both the setup. Bio-waste management we have discussed, vital monitoring, emergency management, except I think our all sisters are not intubation trained, but if we are given the training, that is the only thing I want to say in favor of my opponent. CPR training, ICU shifting, everything they know very well. So my all above problem can be handled by daycare chemotherapy trained nurse at home. So that is my conclusion. Just future new formulations are coming up, like Fesgo and that is already discussed. Subcute forms, IM forms are approved, can easily given at home. We can, if you give more comfort for patient with a less travel, there is a concept of time toxicity, and we take care of that, then the patient will be more happy and it is safe. Even if you oppose, last point that sir was pointing out, it is a crore and crores rupees of industry is waiting for us. Even we oppose it today, tomorrow home care is going to come. So better to formalize it today instead of other people or some corporates and all they are formalizing it. Better ourselves we take initiative and formalize it with the appropriate and practical rules, then it will be the most practical approach. Thank you very much.
Thank you, Kshitij. Please join us here. Now I invite Vinayak to speak against this statement.
Thank you, sir, for the very apt topic. Slides not comes. So, do the daycare nurse will not require any more training to give chemotherapy? That's the topic, and I am speaking for against. Is home-based chemotherapy similar to daycare? That's the question is there, because if you're thinking corollary of what we are asking. So this is the standard thing which is in Apollo, they have quoted it out, and the trained staff are giving the interventions. Here there is a virtual consult by primary oncologist, home care physician. Trust me, it is a homeopathic guy or Ayurvedic guy, and a nursing, and visit is only one. These are the benefits which they are quoting. And coming to MOC, our friend, where they have described their on the website, where the consultants are qualified and experienced to handle. So there is nowhere they mention nurses are as apt as consultants, but even those 8 shifts are very relevant, because that is when we will shut down the whole thing. And so my point is that it's not same, it's different. The caveats and other things are different. Ideally, we should have a evidence based. I totally agree with the last statement. We should have some evidence based documentation, how the process is done. Trust me, there are not. Okay. So are the nursing teams are equipped to prepare and administer chemotherapy at home? Is safety is important for healthcare worker, patient, caregiver? I don't think so, because these are the protocols which are followed in Australia, where they do the daycare home-based therapy. None of those protocols are followed. Even in COVID also we know how this hospital waste are handled. Can you ensure the safety of the chemotherapy preparation when it's sourced from hospital? The distance, the time, there are a lot of drugs which you have to give in short time from preparation. And can chemotherapy waste can be safely discarded in this setting in the home? Bags are fine. They cannot carry multiple bags to place to come and go. PICC, yes, PICs are handled by sisters, and we see that there are issues with PIC handling. Ideally, we have dedicated PIC line teams to handle it. Even in all nurses don't do PIC line, there are specific nurses who do it. As my fellow colleague has agreed that resuscitation is an issue, and in their own centers, apart from them, they hired a professional anesthesiologist to take care of them. So if that is a expectation we have, definitely we should have it for same at home where. This slide will tell what is Bangalore. If I have a resuscitation or there's 8 patients on this crowd who have to come to the hospital, or this situation where you have to drag them in the boats, it will be difficult. So I think it's the nursing team is not equipped to administer the chemotherapy at home. The main question is it medico-legally safe in this time, in this rules to give? So first of all, home health registrations are done at corporate office. None of them are registered with KPME or any of the health licensing authorities as of today. All of them are the extension of hospital with a subsidiary, which are not legally entities. There are not none of us are trained. Those nurses are involved in training of oncological trainings. So most of the trainings are done for the daycare or chemotherapy administration. None of them are actually professionally trained for home-based therapy. Do we have approval? If you take the telemedicine guidelines, there are no recommendations. If you see the bottom line, one of the statement is anti-cancer drugs cannot be given at a telemedicine call, which we don't do it because no oncologist is going and saying it. If medical error occurs, maybe in prescribing, ordering, administration, dose calculation, the $1 million question is, who is responsible, nurse or oncologist? In the curve, even though it's virtually, the guy who is responsible is primary oncologist who has vetted the protocol and given to them. He is responsible, not the nurse. So this is the commonest extraction injury we see, and there is a disclosure, any overdose happens, they'll book the oncologist, senior the better, definitely not the nurse. And in that case, no nurse was taken for the action, because in the medical legally, who has more money are taken for the task. Conclude a statement, I don't think it's medically safe, medical legally safe to give chemotherapy at home. Thank you.
Thank you, Vinayak. Now we come to statement number 3, and that is the most important part as to what happens in case of an emergency. So the statement is, daycare resuscitation tray or crash cart remains unchanged for use in home chemotherapy. 4 is Dr. Amish Vora, who is already here, and after him again will be Ullas Batra. Amish, over to you.
Thank you, sir, for such thoughtful session. Why do we have this topic? I think it's very simple. If the same resuscitation trolley is required, we go with it. If not, we change it. This is something which is the ideal resuscitation trolley which is there everywhere, and ideally if it contains everything what is required either in the daycare or home, you don't need anything. But you know, some people are, I'm not saying this is Ullas, but some people are, they have the full plate in their hand, but they say, mujhe kuch aur chahiye, and they would want something different, and I'm sure he would say something different. So before we go to resuscitation trolley, what are the infusion reactions you all people have seen in last 10 years? Or which are the drugs? So these are all the drugs which are listed, and all of us have seen one or the other reaction in this. I think very, very common are 4 or 5 drugs which we see on a routine basis, the infusion reactions. And what are the type of reactions which I have seen? Infusion reaction and hypersensitivity of different grades, cardiac arrhythmias, hypotension, suddenly uncomfortable hemodynamic instability, gastric irritation, muscle spasm, edema, hypo or hyperglycemia, myocardial infarction, myocardial arrest, and convulsions. So what are the drugs and equipments required for these reactions? Most importantly, what I believe, if we want to start daycare chemotherapy, only nurses are not enough. You need to have an ALS trained doctor while giving chemotherapy, because without a good personnel, everything else is useless. So this is the main aspect of the debate. Should that be different or same? So the resuscitation trolley at Hope, that is a center where you know this Delhi, we have defibrillators and pads, IV cannulas, infusion equipment, airway protection, oxygen mask, central line equipment, various drugs, PPE kit, various algorithms of doing the emergencies, scissors, jelly, sharp disposal beans. These are the various algorithms what we have kept with all the list, which includes everything. I checked this list with the ICU consultant. They said you have all the drugs which are there. In addition to that, hyaluronidase, DMSO for vesicant extravasation, you can keep. IV Livipril normally, which is not there because you know convulsions if it is there, and if you are suspecting some DVT, low molecular weight heparin, which is there. PICC line dressing, chemoport and flushing, which is there. This is the outreach program of England, where they started in 2007, so 5 years data, and they found that possibility of death is 0.06 either in hospital or at home. In reality, outreach program did not report a single death in home. So this is a resuscitation trolley, as I said, in 2 different hospitals, but as I always say, that Ullas will keep saying lot of things, he will show lot of cartoons, and finally you will say, "Arey kehna kya chahte ho?" With that, I rest my case.
Thank you, Amish. Now let's hear what Ullas has to say.
I actually don't know, Amish, what आप क्या कहना चाहते थे? I mean, what you actually showed was, you know, you were showing Hope. Hope is a home care center, or Hope is a daycare center? I mean, I think you spoke for me. I don't need to speak. I don't know, still I'll speak. What to do? I have been called here to speak, no? So, Amish, I don't think you read it properly. It was hospital versus cash cart and home care chemo, not daycare chemo. Hope is a Daycare center. Hope is not a home care center. And that is where the crux of the debate is. I'll stop. 3 minutes, 30 seconds, I'll say for them. So this is basically, I hope the cartoon is clear basically. So cash card when hospital versus home care, is the difference. They all showed me data. I called up healthcare at home yesterday. I said I need something for my own relative. They said, sir, वो हमारा home visit वाला kit होता है ना, जिसमें एक adrenaline और एक atropine होता है, हम वो ले आएंगे. And that is the reality. You can say whatever you want to say, but only one of them is Amitabh Bachchan, and that is not sitting on that side over there. So, crash cart is basically a means of storing and transporting vital equipment which may be required during a code blue, which is a medical emergency. As Dr. Parikh will tell you, if you do not have something, you say, this is, in my experience, I have seen this 10 seizures. And if a 11th thing happens, in my experience, तो हुआ नहीं. Court will say, please go and have the experience in the, in the jail or whatever, not jail, sorry, in somewhere else where you can actually over there. This is the cash card thing in Rajiv Gandhi that we use. And this is exactly, I have taken a picture at 9:30, not me, my resident has taken a picture for that over there. And the emergencies in oncology, that is why I said code blue. Code blue is not cardiorespiratory arrest only, it could be anything. You can have a seizure, you can have a syncope, you can have a fall. Right? Fall also is there, no? You can have an adverse reaction, you can have a transfusion reaction, you can have a side effect of a narcotic, you can have a bleed. Now let us say severe anaphylaxis caused by IV anti-cancer drugs. Amish, a single experience is not evidence, is not a paper, but we have a paper over here. In this, what they are saying is 27 severe anaphylaxis were noted by 5,584. In a month, in a day, we give 250 chemotherapies at Rajiv Gandhi. In 1 year, if we would have at least 20-30 reactions which can happen, or 3 or 4 reactions. Out of this 4, if one person gets, we get dash dash dash. The incidence is 0.031%. The threat is clear. Carboplatin, if you are giving, carboplatin basically, if somebody who has got a 10 carboplatin infusion, 10 by 124, that is 8.1% of people will get carboplatin hypersensitivity. And how many CEO ovaries in NSCLC we see? Lot of none. Even with paclitaxel is 0.93%. Out of this, patient basically had hypoxia, shock, neurological, dyspnea, everything. All of them were treated with oxygen, hydration, IM adrenaline, hydrocortisone, chlorpheniramine, famonite, inhalation salbutamol, everything. These are not available. This may be available in a daycare center. Hope is a daycare center. It is not a home-based center. Now, is this problem a submerged or an emergent problem? And this was an article which was presented. Again, 0.4% is what they write. And again, that is what we are saying. This was in data from the Italian Institute. 0.4% is not less. 0.4% of the 10,000 chemo that are being given is absolutely fantastic. Now, these are the crash cart items which are basically there, which is there. This is a list of crash cart items. If you do not have, your NABH accreditation will go, your JNCI accreditation will go. This is what the JNCI actually said in that, and they said the most important thing if of an incident is when they fail over here. So to conclude, by failing to prepare, you are preparing to fail, and I am sure that is not what they want. And if you don't want to end up with a person like this over here, thank you. And you are as weak or as strong as the weakest link. Thank you.
Wonderful. May I now invite the panelists to also join, Dr. Rajesh Jindal, Dr. J.P. Agarwal and Dr. Arvind Krishnamurthy. Arvind is missing. So, Rajesh, can I start with you? I want to start with you. My question. So, you set up a new hospital, right? You have a new hospital.
Yes, sir.
And do you give chemotherapy at home or do you facilitate chemotherapy at home?
Sir, a word a one-word answer is no. And for that answer is for all the right reasons which you just heard, that medico-legal and safety and everything else combined.
Right. JP, at Tata Hospital also there is no home care concept, right?
Yes, sir. But I have a perspective.
Yes.
Which if you want, I can tell later.
No, you can tell now also.
So I will divide in few things. Let's give me an example of a dialysis, sir. Right, sir? In
Yes.
my perspective.
Sure.
If I can create an environment of a dialysis at home with the arrangement, I may be tempted. So I need to see the patient, I need to see the technology, and I need to see the arrangement, if required, how I can move. So there will be a blood bank, there will be a fluid, there will be a technician, and the hospital. So I need to see all the format. If it is feasible, I want to give a try. So I may fail, but I'll bring all stakeholders and then I'll estimate a risk and then I'll make even a business plan as what you said it. Having said that, few will be no, few will be yes, majority maybe after the third or fourth dialysis, I will say, okay, you can start the home care business.
All right.
Advantage, cost, last, but important. Possibly that if I can make a specific dialysis unit for one patient, cross Hep B and all those problems I will reduce, hypersensitivity I will reduce. So those things what I was thinking, but I need to make a very strict guideline before I jump in there.
So since you, one sec Rajesh, just since you said some may and some may not, let's see what is in the audience. Who thinks that it is all right to give chemotherapy at home? Raise your hands. 1, 2, 3, 4. नहीं आपका नहीं, आपका तो पता है यार. 4 people. Now those 4 can put it down. Who thinks chemotherapy should not be given at home? Raise your hands. 1, 2, 3, 4, 5, 6. So it's like JP said, equal hai. Okay. Now my question to you is, and all of you can answer. When I walk into the hospital or in the daycare center, I know what the environment is. I know what the environment is. Means I know this is the door, this is the window, this is where the crash cart is. In case something happens, this is where the emergency button is. When you go to somebody's home, you don't know what the environment is going to be, right? What is the size of the door to enter the house? Is it on the ground floor? Is it on the third floor? Is there a lift or not a lift? Do you think this matters in deciding whether to give chemotherapy at home or not? I'll start with Bhavesh on this side and then we'll go down.
Yes, sir. So each and every point you mentioned is relevant because it should be, when it is emergency, it's matter of seconds to minute. When you put your hand, it should be there.
It matters, sir, actually. That is the problem, actually. We're talking other things. It is safe. It's not safe. We're talking about life, so.
Sir, I don't know what is the structure of patient's house.
Yes.
But the patient knows what is the structure of his house. And obviously in oncology, it's a shared decision making that we are taking. If my patient is eager to take and there are certain set parameters which he thinks can be complied upon, then I think I can make an effort and we should make an effort to see if that is feasible. It is not like an all or none phenomena, we need to select, but it's not that you can say an absolute no. The patient knows, it's a shared decision making.
Sure, I'm asking for your opinion. I'm not saying one is right or wrong. Rajesh.
Sir, I'll illustrate by a small example. You have a patient who's lodged up in the attic. I won't feel safe, going up to the attic and administering him drugs because I'll not be able to shift him out in an emergency.
All right. JP.
I think I need to really see the environment where I will give. I will see the type what I need to give. I will see the response time which will take. There are like I told you, sir, there are 5-6 things I will like to see before I say, okay, go ahead. And definitely a regulatory permissions are also required. Or it should be regulatory convenience has to be made up to the local or state levels or whatever is required.
All right.
Then I am for pro.
Sorry,
Yeah, so sir, I will give my perspective. I am looking after, not looking after, just monitoring our MOC home care, not chemo, but palliative care from outside. So what we were discussing, first of all, we are not giving chemo at home. We are only giving few injections like bortezomib, dexa, and very like subcutaneous injection only at home. But what we were discussing, if we want to decide, if we want to give a chemo at home, what points we will consider. So the first point what we were discussing, a visit should be done at a patient's house by a doctor, home care doctor, to understand patient's environment, to make all arrangement in advance. Then the second, oncologist will decide if it is possible to give that chemo at home. If it is a taxane, if it is an antibody, he will say no. And of course, it is a first cycle, second cycle. And then after, if both things, and third thing is the willingness and the support from family. If everything in place, then we can think about giving chemo at home. If it is something is missing all these 3 points, then we should avoid, we can give consent.
Okay. Amish.
So addition to what everybody has said, one of the important point what I would consider is proximity to the nearest ICU. Every hospital, wherever I have worked, from the ward to ICU, it is around 8 to 12 minutes on an average. In Tata Hospital also from 11th floor, 7th floor to ICU would be 8 to 9 minutes. If within 10 minutes, if there is an ICU available, whichever ICU, if ICU is available, that would be one of my important factor.
Ullas.
So my point is very simple, sir. Accidents don't happen every day. They happen only once. And once they happen, you had it from there. I have lost a patient to cisplatin allergy. I have lost a patient, okay, I'll not comment on that. I've lost a patient to something else also. And we have had a case going on against our hospital that you knew the culture report in 48 hours and you started the antibiotic 6 hours late. So that is what has happened. Not willing to take that risk at all. No way.
Yeah. So, is there a consensus? Yeah, somebody wants to ask. Go ahead.
I want to, mic on? Yes, it is. Yeah. So I want to know the medico-legal implications.
Can you introduce yourself? I don't know you.
I am Dr. Sarana
From?
From Namakal, where Dr. Bhavesh is from.
Sorry.
So we are very fearful of medico-legal implications. Imagine, a nurse practitioner or somebody who you deputed, you analyze everything. Most probably the first cycle is not going to be at home. You would have given 1 cycle at the hospital, made sure that he is okay, and probably second or third cycle you will consider at home, and the patient dies. No, now for a procedure which has not been legally approved to be given at home, is it murder? Like Michael Jackson, had propofol, and there's a murder investigation going on for the thing. So what is the medico-legal implication? Now today, if you are a healthcare giver, suppose I am a surgeon, and there is a ICU in the hospital, patient collapses, and I am not able to resuscitate despite the presence of a ICU intensivist, I am liable to be sued because that was a specialist who was there. Whereas at home, anything happens, what are the medical legal implications for the person who asked the chemo can be given, for the nurse who has given the chemo, and suppose a death happens, is it a hospital related death or is it a... So whenever problems happen, they tend to magnify to such a great extent. So as surgeons, we know, if somebody dies on table, the implications of that becomes so huge. Similar to, we've seen our share of complications like Dr. Ullas, Batra said. So what are the medical, it's not Swiggy or Zomato where they're going to give food and we are going to eat it at home. So these are very tricky things, I think.
Right. So the one statement that he made was that there is no regulation that allows chemotherapy at home. Is there a regulation that says chemotherapy should be given only in one XYZ place?
Sir, I have Supreme Court lawyer and High Court lawyers one page because we wanted to start that in hope. So their final conclusion was the law does not say that you can give chemo at home, but the law is silent also. It does not say that you cannot give. So they said if you want to start, you can start, but I had called you also. They said if one case goes up to High Court and the High Court judge will decide, and then that will become the law, till that time you have to take your individual risk.
So, one sec.
Can I also?
So, one sec. We'll take one point at a time. I want to answer his question. So, have you understood answer number one?
Yes.
That there is no law that prevents you from giving chemotherapy at home. Is that clear?
Yeah, it's clear.
Okay. Ullas.
I forgot what I was.
See,
Okay.
the issue with that is, for a person who's, the risk is totally on that particular person.
No,
So
we
who's willing to
are
risk
coming to that point. But the first point is that there is no law that prevents chemotherapy from or any treatment being given at home. There are several home care services that set up an ICU at home also, full-fledged ICU at home, right? Rajesh.
Sir, we may not have a law of giving chemos at home, but we have a law of safe practices. Like we have to act in the interest and the safety of the patient. So
I don't deny that.
Yeah.
I don't deny that. So now let us say what he said, that a patient was being given chemo at home and the patient died. How will you defend yourself? Shall we go the other way around? Ullas, we can start from you.
So I will not give chemo at home, sir.
Okay, fine.
So the point is, if I have given and something happens, I'll say, okay, fine, my XYZ doctor was there, I had a crash cart ready, I took a consent from the attendant, and everything, a nurse was there who was prepared, first chemo was not given over there. So all these points, I will make sure that it is there, and I'll take a signature prior to them that we don't want hospitalization because of XYZ reason. That is what I would do before giving chemotherapy.
Okay. Amish?
Same, sir. There's nothing new.
Kshitij?
Yeah, the same thing, everything we should do in advance with consent, and then only we go ahead. And one more thing is that these sites, they claim that they're giving chemo at home. What they claim that a trained MBBS doctor will be there sitting, and the second thing, ambulance is ready outside home. And so if something happens, we can provide, and there is a data that the allergic reaction can happen. This is what I will.
Right.
So I think if I have taken care of all the stakeholders upfront, documented, death can happen sitting, sir. Means I have given chemo today, death can happen tomorrow also, right? Known, sir, electrolyte imbalances.
How will you defend yourself?
Defend is that I have taken all precautions, documentations are clear, so it can happen.
Okay. Rajesh?
Sir, I think I would agree with Ullas and Sir JP.
Okay. Vivek?
Correct, sir. I think not just a simple consent, but a proper legal agreement which mentions that all pros and cons consequences were explained. And even after that, we take on-table death consent, high-risk surgery consent. These are taken. So, similar consent should be taken.
I think the death in hospital or death in home care is same. Risk for a doctor is same, because we may be little more question about the conduct, but the consequences are same.
Okay. I'll take a point from there that death at home and death at hospital, are they going to be seen in the same way with all the equipments except the doctor being there, the primary doctor being there? Is it going to be taken equal in the eyes of court or law? If yes, then it's okay. If no, then the straight answer is no.
So I will add to it, since I was preparing for the debate, you have a code blue. After code blue, you have a crash cart. Then what happens is you should have a BC, the ALS team and everybody who should come. You should have an anesthetist and you should have a resident medicine and everything. The court may just ask you, okay, fine, you gave this. Where were the other people? Why was this not, what were you doing at that time? You were doing this also, that also. Where is that trained manpower over there? So, reasons for me not to really do that.
Sir, the court will also ask the patient party that why did you allow this treatment at home? Didn't you know the risk?
Patient party will say doctor didn't, patient party will say
don't
doctor.
be under that impression that the court will ask the patient.
They will not ask anything.
Let me give you one unrelated example, okay? And it has been in the newspapers recently. There was one person who went adult, 21-year-old, who went to the orthopedic surgeon and said, I am very embarrassed with my short height, I want my height to be increased. Now it's possible to do that. They did the surgery. After that, the patient, nothing happened to the patient. Patient recovered, but the parents went to court.
Yes.
Okay, why this surgery was done when it was not necessary. And the court found the doctor guilty in spite of having proper consent. Okay. So please don't be under the impression that the court is going to question the patient party. That is not going to happen. Now Vivek, I'll also like to ask you, if you know, since your hospital is providing home care services. Not providing? Okay. Anybody's hospital is providing home care services?
So when you say home care services
Whole
or palliative?
chemotherapy.
Chemo, no.
Yeah.
I don't think right now anybody is providing that services. There are few incubators which is supplying in Mumbai, and somebody rightly said that they are saying that there will be a doctor attending, there will be an ICU standing outside your home. I think we feel that it has never to be happen, but let us think positively. I'm sorry, I mean this hypothetical. We can decide few molecules which can be given. We can decide few conditions like stage 4 cancer, we are giving palliative, methotrexate, FAP, whatever, that can be thought of. Secondly, as Amish rightly said, that there has to be an ICU which is very close to that, and the guy who is working in Mumbai, he said me the same, that I have got liaisons with proximity hospital and they can do it. Now, I understand that legally we are responsible, but at the same time, all of you are saying that there will be a consent. Now, if it is an informed consent by the family and the patient, like in operation theatre, we say that you are going to die in 2% of the cases. Same way, if you are taking a consent, patient is asking that please do it at my home. In that case, Sahib, do you think that it will create a lot of responsibility for us?
Can I?
Can I answer that question first? So, 8 days ago, in the newspaper, you will have seen the judgment given in a situation where the patient's consent existed. The patient was operated for some gallbladder illness and the patient died. Okay. What the court said, just because the patient has signed the informed consent does not absolve the doctors of negligence. So, consent is one part, definitely it has to be there, but after the consent, the due diligence has to be done.
Yes.
And therefore, whenever we go to a home care or decide that we want to give, besides consent, due diligence of the environment and the family suitable for the giving the chemotherapy, and a checklist which allows you to certify that you have done the due diligence to say that this is a reasonable environment where it can be given safely. So that's why I was asking if there is any institution that is also already providing it, then do they have a checklist?
Yes.
That's what is being used.
So component 1, that environment has to be decided and approved by some of us. Some of us hospitals guy would go and check that yes, it is possible. So that is first, due diligence is first. Second, the doctor has to be convinced that this could be done. So an intelligent man who is professionally competent to decide. So I know that you are not going to give any biological therapy, you are not going to give any taxane, and you know that you are not going to give carboplatin or cisplatin. Okay, it is like weekly course of gemcitabine. So you would decide what can be done there. The third component would be they have to be explain everything and counsel that these are the possible complications. Like 27 patient in 2000. I would presume 100 patient in 2000. Okay, so the percentage wise it is small. So we explain them.
Understood.
So the percentage wise it is not small, sir. Tata Memorial gives like 10,000 something, I was writing 0.02%, and if 0.1% of that goes into litigation, they will be there only, sir. One. Second is, sir, the courts will always ask, okay, fine, the problem occurred. What were the steps you took after that? And if you find out that, you didn't have a doctor or an ambulance or something, you didn't reach, whose fault is this? Is it patient's fault that the ambulance was not able or something? Unnecessary क्यों करना, sir?
नहीं सुनो, वो आपका perspective है.
Wait. So there is one more point that we have to discuss. Now, what we have discussed is that one personnel goes to the home to decide whether it is suitable or not. Then a doctor certifies that it is suitable and then the treatment happens.
Yes.
In other words, the hospital's resources to do this will be at least 5 or 6 times more than if the patient is coming to the hospital for the treatment. That means the cost to the hospital is more. So, are we going to charge the patient 6 times more than being given the chemotherapy at home? That's the question.
Yes, sir. It has to be. It is a privilege we are offering.
So, Vivek.
It's a cap, golden cap.
Yeah. So,
I think, sir, in my slides, I showed that the studies have shown that home-based treatment is costlier as compared to this. In what because that is exactly hospital-based, protocol-based done. So the cost is more. Second point, I just wanted to say this fact that, sir, I think it will be interesting because home-based dialysis is happening. And I'm sure a death must have occurred and a case must have occurred. We should try and access that document as to what happened when the home-based dialysis was done and a death occurred. Whether is there some sort of a medical legal case? That will be an interesting.
So, yes, Sanjay.
Sir, there are protocols written from a busy center of a metro. You just go with this protocol and take it at your home place. PSC or GP place. It is equivalent for that GP or none of them is trained for giving chemotherapy or anything else, or extravasation is also occurring there. Then it is equivalent to an home care part also.
Sir, the letters that are given from at least our center and Tata Memorial that I see are to the oncologist. They're addressed to an oncologist.
Every city and town or a level 3 tier.
So we should change our practice. Instead, sir, two wrongs don't make one right, sir. Instead of saying that you are giving over there, then correct that wrong first. Don't make another wrong to make that one right.
So, let me give you the legal point of view on that. If I am writing a protocol and the patient comes to you with the protocol, then what you do with the protocol is your responsibility, not my responsibility. Okay? Just because I have written something doesn't mean the patient is fit or the environment is fit or you are competent to give. That is up to you. Okay? Understood? So, now I want to come back to one more important question that was asked, what is the medico-legal implication? But before we reach the court, there is something else that we have to worry about. During COVID times, how many times did you see on television that people who are going at home for surveillance are being chased away, stones are thrown at them, people are coming out with swords to hit them. So, now supposing something like that happens, untoward happens, patient dies. What about the safety of the healthcare personnel who are in the basti or in the environment where they have no friends and no security support from this?
Same as lorry driver who hits it and what he does.
To run. Sir, let me tell you, in Ahmedabad Municipal Corporation medical colleges, they keep bouncers nowadays, officially. Because that happens very frequently now. So they keep bouncer officially.
So now when we go home, we should have a nurse, we should have a doctor, we should have a driver and a bouncer. Okay, 4 people have to go there. One of the common questions that was asked to me earlier was, what if the chemotherapy vial breaks at home? Okay. So Vivek, what would you advise in such circumstances?
I would ask that to carry multiple, at least to if somebody is prepared, then at least he must be carrying those spare. So suppose if you are having a crash cart, but you are saying that you are just carrying one vial of adrenaline, and if that is broken, so I mean that should not happen. So of course spare medicine should be available if one is prepared to do that.
So in business there are 2 concepts. One is just in case, and the other is just in time. Okay. So which will you follow when you are giving chemotherapy at home? Just in case or just in time?
I think, sir, it is absolutely about selection. And if there is a possibility, if I have been due diligent and I have given enough evaluation whether this is feasible or not, after that it happens, then of course it's my failure. I have to preempt whether this situation can arise in this treatment or not. That is what it is.
Rajesh.
Sir, I want to ask you another question in the same vein. I mean, is it any different if I break the bottle or I break the ampule? I mean, I have already reconstituted the drug then the whole thing falls and it spills on the floor.
No difference.
And I just break the Taxol vial.
As far as the patient is concerned, your chemotherapy will be temporarily postponed or terminated at that point, right? As the vial or the bottle falls. Now what to do next? In the hospital, what to do next, we know. 1, 2, 3, 4. At home, what do we do?
So immediately, so there is an immediate of the area where the spillage has happened. So the home care nurses are also will be NABH trained.
Spill management is one part to prevent biohazard.
Correct.
Okay, let's forget
so what is that aspect
now
you are
the question
asking?
is, the team has gone, the team is going to do the process is aborted, the team comes back. Are you going to bill the patient or not?
Yes.
So the patient will say, you did not treat me, I was contracting you to give me chemotherapy, you have not given me chemotherapy, why should I pay for it?
Visit charges
These
would
consequences
be there,
should be discussed in the bill, that this can happen, and there is sir, if you are buying a television, you have paid for it, and in the transport it breaks, will that television company give pay you back? They will not pay. So it is same, sir. The patient has to be billed, and if this untoward circumstances have occurred, they have to understand this is a part of the agreement.
I have ordered something on Amazon. Okay, Amazon guys are delivering it to my home. When I open the package, it is broken. What do? I don't accept it. It goes back. It doesn't get billed to me.
But sir, that is discussed in the
contract. Let me explain. Now your personnel has come home. Your personnel are handling the vial. They have made it fall. They have broken it. What is my fault? Why should I pay for it?
What happens in a hospital? If
No, I am talking about who is to be billed.
in hospital, what happens? What happens in hospitals?
I am asking you, you tell me.
You see, normally what used to happen was the nurse, poor thing, was getting billed. Her salary would be probably...
so patient is not billed.
What we
Patient is not, that is the important point. Patient is not billed. Now you answer that.
One second, Purvish. As a senior, what I would do is, I would get that vial replaced at
our question is, should patient be billed or not? They are saying yes, so I am asking.
So within 1 hour in every metro, the drug can be delivered.
That is, so you are saying it is not aborted, it is delayed.
It is delayed.
So now the people who are working there, instead of spending 1 hour to do the chemotherapy at home, they have to spend 2 hours.
Unfortunate, sir.
Will you bill for 2 hours or 1 hour?
No, sir. There you will bill. My point is that they should not, visit fees should be given. All these things are normally included in the consent. Visit fees included, chemotherapy charges are not to be taken. And if 1 hour delay, invariably, if it is fault at our execution place, we can't bill patient twice.
Can I ask you one stupid question, sir? Why are we discussing this question, sir, in the medical legal thing, sir? This who gets billed?
Because if you have seen the news today, it says that corporate hospitals have been overbilling. CCI has said now. And then they can impose including Max Hospital, Fortis, Apollo, they are saying that they have been exorbitantly billing. And the penalty could be 40% of their annual turnover. So if the turnover is 1,200 crores, they can give a penalty of 400 crores for the previous 3 years.
I told you it's a stupid question.
So that is, yes.
I think this is a very pertinent question you have raised, that who is going to be billed. But then trying to find answer to this in this forum, would it be fair, because it will be too unilateral?
Yes.
Okay. Unless the other stakeholder is there, this is number one.
Yes.
Second, last week was the International Patient Safety Week. There was a issue day before yesterday in a meeting that iatrogenic injuries, who pays the bill for the management? In corporate hospitals, in government hospitals, particularly in free beds, government takes care of. Even in paying beds, but in corporate hospitals, very simple, very common, decubitus ulcer.
So we are not talking about injury to the patient, we are talking about financial injury. Who is, where the financial injury, the patient or the hospital? I think we have run out of time, and there are a lot of questions. I think we will continue. Yeah.
Chellu suggestion apu.
Bolo na.
As a top group icon, you know, we are the group, why not we create a white paper and submit it to the Department of Health? Because, you know, this is a time we can do some corrective measures. Otherwise, you know, there are a lot of incubators, they have started doing it. And
Sir,
unfortunately or fortunately...
Sir, that is the very purpose of doing this.
Yes.
We want to bring out a white paper.
Yes, sir.
But what should be included in the white paper? We are discussing what are the important points to be included.
Yeah. So
Then,
for that, you can create a small questionnaire,
yes,
and all of us will respond to that.
Right, right.
Sir, I think whenever such thing is happening at home care, it is all package based. So if we have set a package, anything happens has to be absorbed.
Yeah, okay.
Sir, aftercare is also needs to be inbuilt in that.
I think as a matter, home care itself is not registered with any health authorities as of now. I think that should be asked because none of the healthcare organizations are business entity. They are not health entity. So that is one thing which I think a part of should be there.
Sure. Okay. I think we had a wonderful discussion, a lot of interaction from the audience also. Panelists, thank you very much. The people who spoke for and against the points had a fantastic job, and I think we will use all these points to come out with a white document. So